Hello. In this video, we'll discuss imaging of the ribs. Imaging of the ribs is easy if you understand the protocols. And there's just a few simple rules we have to follow. First of all, you always do a minimum of 2 projections. And second, those projections are based on the area of the patient's pain or injury. So the projections you do for every patient may be different. So let me explain. Your first projection is always going to be an AP or a PA. And again, as I mentioned, it's based on the area of pain. So if your patient comes in with anterior rib pain, you want to put the anterior side closest to the image receptor because we know it provides better detail. So your first picture would be a PA. So if they're having anterior pain, you're going to do a PA. If your patient comes in with posterior rib pain, again, affected side closest to the image receptor for better detail, we would want to do an AP. And remember, you're imaging the side that hurts, right or left. We're not doing a whole chest x-ray, okay? The second projection we always do is an oblique. And we are going to do 45-degree obliques. Now, some clinical sites will do 30, some will do 60, but 45 is pretty common industry-wide, so that's what we'll do in lab. Certainly, if your clinical site does different obliques, you're just going to adapt to their protocols. Now, the purpose of the oblique is to elongate the rib. If you think about a lateral chest for a second, all of the ribs are superimposed, making it very difficult to see individual ribs and look for any pathology. Because a lateral of the ribs wouldn't be helpful, an oblique is our next best thing. So there's a couple rules when you're doing obliques. First of all, if the patient has posterior pain, you roll the affected side towards the image receptor. So posterior pain, roll towards IR. So for example, if your patient comes in with right posterior rib pain, you would do an RPO. Okay, not too bad. You'd do a 45-degree RPO of the right side, right? Let's say your patient comes in with anterior rib pain though. The rule is a little bit different. Anterior rib pain, you have to roll the affected side away. Oops. Roll affected side away from the IR. If you roll the affected side towards the image receptor when you're doing anterior obliques, you'll actually get foreshortening, which is the opposite of what we want in elongation. So let's say your patient comes in with left anterior rib pain. Affected side away when we're doing anterior obliques. So we're going to do an RAO. Okay. All right. The third thing to consider when positioning for the ribs is the breathing technique. If your patient has lower rib pain, you want to make the exposure on expiration because you want to raise the diaphragm out of the area of interest. So lower rib pain, you expose on expiration. Okay, let's say your patient has upper rib pain. We're going to make that exposure on inspiration because, again, we want to move the diaphragm out of the area of interest. Okay, so for every rib patient you do, you're doing an AP or a PA, you're doing an oblique, and you're considering your breathing technique. So let's practice. Let's say your patient comes in and they have lower left anterior rib pain. How will you position your patient and how will you breathe them? Okay, well, my first image, because they have anterior pain, I want to put that side closest to the image receptor. So my first image is going to be a PA. of the left side. Then I know I have to do an oblique. And when we have anterior pain, I know I need to roll that side away from the image receptor. So left side away, I'm going to do an RAO. And they have lower pain. So I know when they have lower rib pain, I need to make the exposure on expiration to move the diaphragm up and out of the area of interest. So expiration. Okay, let's try another one. Let's say my patient has upper left posterior pain. Okay, posterior pain for my first picture. I know I want posterior side against the image receptor. I'm going to do an AP. Now I need to figure out my oblique. Well, it's posterior pain. I know I roll posterior pain towards the image receptor, and it's the left, so I'm going to do an LPO. Last, my breathing. I know it's upper rib pain, so I want to do this on inspiration to drop the diaphragm out of the area of interest. Perfect. And I have a whole bunch of scenarios that we're going to practice when we're together in lab. Okay, there's just a couple other things that I want you to be aware of when you're imaging the ribs. First of all, a lot of departments will ask you to put a BB on the area of interest. So I'll just make a note here, BB on area of interest. And really the goal there is to kind of guide and focus where the radiologist should look, okay? So you can just ask the patient to kind of point to where it hurts and put a little BB sticker on that area. The second thing I want to mention is that some departments, even if the patient only has upper rib pain, some protocols or departments will ask you to image upper and lower. And that's okay, that's just their radiologist preference. In lab, we're going to do specifically upper or lower, but at clinicals, you may be asked to do both. And the last thing I want to mention is if your patient is having rib imaging as a result of trauma, which most ribs are as a result of a trauma or a fall, you always want to include a PA chest. So include PA chest x-ray for trauma or falls. That is so that the radiologist can look for anything like a pneumothorax or a hemothorax. So always include a one-view chest when the patient has had an injury. Okay, all right, what are your questions?